Good morning, everyone. And today we'd like to start with James Berger.
I'll be doing the roll call. When I announce your name, please announce if you're present. Claudia Cohn,
Present.
Diane Wilson,
Present.
Sarah Barnhart,
Present.
Lisa Gordon,
Present.
Ray Goodrich,
Present.
Daniela Vermillion,
Present.
Cassandra Josephson,
Present.
Jed Gorlin,
Present.
Michelle Kim, moving on to Yvette Marie Miller,
Present.
Michelle Kamika,
Present.
Paul Ness,
Here.
Teacher Pandy. Moving on to Lynn Ewell. Moving on to Megan Delaney,
Present.
Lou Barnes,
Present.
Benny Hang,
Present.
Stephanie Pouch,
Present.
Glenn Ramsey,
Present.
Casey Syme,
Present.
Eric Santiago Justiano. Moving on to Susan Galil,
Present.
Josh Penrod,
Present.
Peter Basarajavu,
Present.
Diane Corning,
Present.
Ann Eder. Moving on to Scott Brubaker,
Present.
Marilyn Levy,
Present.
David Stronsek.
Present.
With that, if I've missed anybody, please let me know at this time.
Michelle Kim's present.
Thank you, Michelle. With that, we do have a quorum. Meeting can progress.
Before we begin, I would just like to clarify something for the record. Yesterday, we discussed whether FDA requires barcodes, and it was mentioned that they do not. But in fact, let's see, please see, but in response to a question, I said FDA doesn't require, but the labeling regulations do require machine readable information, the FDA requirements for blood. Thank you. This morning, we're going to start with an overview of tissue service gaps and recommendations, and we will start with Scott Brubaker and Tim Pruitt.
Yeah, we just wanted to go over and to say what recommendations have been made previous, which have not been followed. So in 2009, there was a gap analysis, which was done not by this committee, but through. They made recommendations for blood tissue and organs. And these are, we've just clipped out here the tissue recommendations that came through and moving forward. So as you can see, the issues have been one of traceability, which we talked about a fair bit yesterday. Develop a system that employed bidirectional traceability from donor to recipient, which would use unique identifiers linking the donor to covered organs and tissue. We don't have a uniform linkage, but as Scott has pointed out before, that's not ever really been the total problem as going through to anywhere back for tracing tissue. All adverse events possibly related to tissue grafts should be promptly reported and investigated. That's pretty vague language, but it has a real way of trying to figure out what numerator. Assess the adequacy of the current language and the process of informed consent for tissue and implantation. Assess the adequacy of current oversight mechanisms to ensure patient safety in tissue recipients. And then to develop a uniform questionnaire for donor screening. That was recommended in 2009. Slide. Then in 2015, this committee made the following recommendations. When it was after this came. Availability of that. So this was about availability of tissues. For the impetus for these recommendations came about. There was a question about the availability of tissues at the time of the crisis. Did we have a sufficient backlog? Sorry. Was there a sufficient supply of tissue to meet the needs in the event of a national catastrophe? And particularly, it was very concerned about skin being available at that time. But so these were the recommendations then that came out of those particular, the need and everything else. So the first one was to establish the use of ISBT 128 code as a universal standard for mandatory implementation. It was primarily there that we were trying to, that there was a need to look at an understanding of what is the linkage back to the donor and not necessarily to the processor. Establish an aggregated database system for all organ and tissue donation. Promote integration of transplantation records into a searchable electronic patient records, into that is HRs or the electronic medical record, and to have interoperability of records across institutions. Imagine what a headache that's been and nothing has happened. Establish mechanisms to assure that patients are informed and provided traceable records from receipt of the tissue product, and establish oversight mechanisms that cover healthcare settings engaged in tissue transplantation to ensure all applicable standards are met. Tissue's establishment of records, bi-directional traceability and surveillance. Global effort. And then to engage in the professional societies and organizations to help develop clinical practice standards in the areas where there's certainly existing gaps. At the end user level, particularly for dental and outpatient facilities, podiatry and orthopedics. Promotion of educational efforts for predominantly the concept of meaningful patient-informed consent, participation in activities that assure tracking and tracing of tissue products, including feedback reporting and product disposition, then patient adverse event outcomes related to tissue. Provide controls and incentives for stakeholders to accomplish and comply with the above, and then to establish and implement enhance existing mechanisms for international collaboration, data sharing outcomes of tissue transplantation, and particularly in conjunction with the World Health Organization or the World Health Assembly resolutions. I think that's it. I don't think there is. Is that the end slide? Yeah. And so, as you can see, as listening to our discussion from yesterday, we haven't made a whole lot of progress on those. There's some things which have been done. I mean, and I was talking to, we were talking last night, Diane was saying that the tissue availability issue has been dealt with somewhat through, yeah, in terms of making availability and responsiveness to international needs and local needs, at least for tissue availability. But a lot of the other things haven't been done. And the question, of course, is why haven't they been done? And this is the system approach that we wanted to address moving forward. So when, in response to the TB transmission, we have established these work groups that we have put together to look at the processes from donor identification all the way through to tissue use and identification of potential adverse events as to how do we do it? Do we have, and we set up the work groups that were consistent with the public-private kind of approach, where we brought in the regulatory side folks and actual providers who do this stuff and just try to figure out where are the gaps and what can we do to fill them? And how can we address them in a practical way? Because we actually want to get something done here. And we want to set up priorities that can come up and to say, these are the things that really do need to be fixed moving forward. So what we'd like to do now is just to discuss the four areas, the four domains that we dealt with. And you can see they were up here. We looked at the initial one, which was how do we identify tissue donors or any deceased donor? We're not going to talk too much about live donors at the present time. And to say, how is it that we can, how do we identify them? How do we do the processes? Are there gaps in our current biovigilance process? Then we did a tissue processing component. We looked at then the tissue end after the product gets packaged and shipped out. How does that happen? How does it get traced and tracked from, from the processor to the end user? And then afterwards, how does the recipient of tissue, how do we identify the adverse events and report them back? What do we actually do? And we thought we'd like to close those loops from beginning to end and to look at where the gaps were. And so we're going to do this. I think Scott's going to do the first two, particularly from the FDA component. I'll do the last two. And I think we'd like to make this reasonably informal, but also we want to get through it all and then to set up a hierarchy of things that we think that we can make as recommendations to the secretary to actually get something done this time rather than just have it sit in a inbox file.
And to summarize too, those other slides, we found that the work groups who looked at those, we didn't really focus on them, but we ended up, and this was actually probably our fourth meeting, we might have looked at them, but you'll see a lot of it repeated again. But we've hopefully phrased it better this time, more concise. It's not a big list. There's a lot said in a recommendation though, that's important. Some of them may seem a little wordy, but if you read it carefully, it's purposeful to do that, to describe it as well as we can. So what I hope this group can do today is that we'll refine that wording to make sure it's clear who is responsible, who it's directed at, who should take an action for any recommendation or even be involved in it. So hopefully we'll get there. And, you see the four different groups. It's basically, we're trying to cover the life cycle of a tissue product. And hopefully you don't get to the fourth one that happens, but should it happen or be suspected to happen, then that group took care of that. And we had really good subject matter experts. They were excellent, I think, for each group. And they came up with, as you look through that 25-page document, that there's excellent information in there that should be referenced, later. I think that it'll be very useful to look at that as this moves on. So if we could go to the recommendations for tissue source. Again, we did meet, each work group met 4 times since the formation in early 2023. Oh yeah, this is the editable version. So the first recommendation is, I will read the first one and the second one and the third one, because I think sometimes in context, you'll want to see all of these first. So to close gaps and to promote collection of information that could inform donor eligibility policy when screening donors of cells and tissues, standardized donor medical history interview forms and related tools should be developed and recommended in guidance issued by professional societies and regulatory authorities. So, as you're looking, as I'm reading these, think about too, we were well aware of what's happening in blood and what's happening with organs. Number 2, is it okay if I just read the 2 and 3? I can't hear.
When should we add information to
Yeah,
what you
I'll
want to
go
know?
back. I just
You
wanted to
just want to
read.
go through three and then you want to ask us? Okay,
Then we'll go
I
back.
just,
Yeah, sorry. Number two, to optimize control of contamination, effective practices surrounding cell and tissue recovery / acquisition. Recovery is for deceased donation, acquisition is for living donors. Those procedures should be identified and standardized across industry. Number three, to inform cell and tissue donor screening policies, information collected from investigators and adjudication processes involving reports of probable transmission of disease to organ or tissue recipients must be disseminated widely by all groups involved in investigations. So if we go back to discuss more about the first one, I think that's what we want to do here. Is it understandable, I guess, is one question to ask.
Go ahead, Cassandra, then I'd like to speak.
okay. So I read this and then I had read the stuff underneath it, like to give the background for it. And what struck me as, two things struck me as not clear enough is it says to inform cell tissue donor stuff, but I mean, I know it says to close gaps in the number one, but I'm a little confused about what are the exact criteria for the donor screening policies. It says to inform, but like, I guess I was feeling like there is a gap in what we should be saying, who should be eligible to be, that tissue should be obtained from. And I know there's an act, I know there's like some act that says that there's a formal suggestion of what is there, but I feel like it said there was no gap there, but I feel like there is a gap. Because remember, it made a conclusion under each thing and it said there's no gap in who should be approached. And then it also said that it's up to the medical director's discretion. And during inspections, people don't really question it because the medical director said it was okay. So I felt like there was a lot of vagary around exactly who, which brings me to what happened yesterday, right? Why was an 86-year-old person, all that kind of stuff. So somewhere in here, I don't feel like that comes out as part of the recommendation to make it clear who should really be eligible to be approached to then become a tissue donor. Does that make sense?
Yes.
I don't think it's our role to say that because it's the experts who need to decide on these criteria. That's my take. And so my take on this, if gotten Tim email, I think we should be saying more directly, an expert panel needs to be assembled to develop a donor history questionnaire. That will be, I didn't say this, but that will be approved by.
Well, the correlation here with the donor history questionnaire is what happens in blood. So the professional association.
I got that, but I didn't feel like that was well defined for this, and maybe we need to say it needs to be defined, is what I was sort of trying to say.
Susan, Jed, Daniela, then Sridhar.
Yeah, I just want to clarify the situation with blood. There's not actually a mandated uniform donor history questionnaire. There is a tool that ABV has developed, and FDA basically they review that tool and approves it as an acceptable donor history questionnaire. It's not a mandated tool, but the reason that many blood banks have adopted it is that a licensed blood center who adopts that tool does not have to otherwise get their donor history questionnaire reviewed by FDA. So it's a questionnaire that basically has been pre-approved by FDA as meeting FDA criteria. And I don't know exactly what the process is for tissue banks, whether they have to get their donor history.
No.
So, if there's no FDA requirement to review the tissue bank questionnaire, there may not be a motivation for tissue banks to adopt a uniform tool. The other thing I wanted to mention is that the tools that the ABB provides are not just the questionnaire. They have flow charts that tell you what to do with a yes answer. And that's really where so for example, if you had sort of a screening question, is there evidence? That's not going to be sufficient. You sort of drill down, okay, what should you be looking for? What are the criteria for accepting the initial screening analysis? Sort of a flow chart. Oh, here's the additional.
Yeah, all of that exists already today for eye donors, tissue donors, and organ donors. It's called a UDRE. We put together a similar task force and had a stakeholder review group of all of the federal authorities, even from Canada, they were involved to review what the forms would look like. And, the questions, the flow charts, everything. There were even 2 guidance documents that were developed for implementing the UDRE and for it's just there's all of these tools available already, but they're not voluntarily used. I think part of what this was about was to make sure that happens, and they're kept up as well. So AABB does that, I guess, for the profession, right? But also to start, we talked later about data collection. So if everybody's using the same form, then you can somehow mine some data from that, and that can inform policies. Because you learn from what's an acceptable and an eligible donor and what's not an eligible donor. So that's where this is going, is to try to get something done that's just like in blood, but take it to, take what's happened further. Because, we see at FDA, there's a process where you can request an exemption from the regulations in Subpart C or Subpart D. So Subpart C is donor eligibility. And we see coming in, and I don't want to identify a particular profession, but we often see that their forms, their donor medical history interview forms, as we call them, are inadequate. And they get cited at inspection for it. They come in, this donor, can we, if we mitigate the risk by going back and screening them correctly, is it okay? So we see that all the time. So there's constant errors in donor screening in the HCTP industry is really my point. So why can't they just all use the same type of form? At least, the basic form to cover the regulations and even cover their standards. So we did that, and it was actually, for organs too, and for corneas and sclera and for other tissues. But again, it's just the uptake. I don't know. I don't know if AATB knows. I asked the question a year or so ago, didn't get an answer. But how is it? How many how many organizations are using this and all the tools?
One of the things which is I don't want to say if it's a problem, but we don't have a uniform filtering source as to when a donor gets registered in the country. We don't know how many tissue donors there are. We do know how many organ donors there are, but we have no clue as to how many tissue donors or eye donors there actually are. Well, the eye donors, I think we have a better idea in terms. But the data that goes in terms of the collection of screening material, and the importance here is, what do we do how do we screen donors? Do we screen them by testing results, which is like in the MTB one, we don't culture for TB. We don't have a thing. But when they finally did the implementation and put in a PCR, as was noted in the second transmission, low inoculums aren't 100% protective in terms of, or being able to identify it. Whereas the culture did come up, but came up very late. So the question I think we need to come up with here is, how much of this is screening but predicated by history or just basic demographics, the 86-year person on dialysis, versus how much do we depend on safety for testing related results. And the results that we use in organ transplantation are a lot different than what we use in tissue transplantation, because we have a higher risk acceptance, if you will, on the organ side than we do for tissue and for blood. But that's okay. But is there some way to close the gaps between the various products that come out of deceased donors and to make it make sense? One of the things that we don't do that we maybe should is to use a central repository for donor identification, so that people who donate, which we didn't bring up here, are registered at a time of a different place, so that anytime there's a deceased donor, you go to the organ center or the donor center. We have such a thing in existence today with the OPTN, and I think this was what years and years ago was proposed with the Sentinel network for transplant transmission, is to say, can we get a common donor center available that you can't use donor products unless you're registered inside of a system. Now, it won't necessarily guarantee that all these things are complied with, but it would have a way to at least put a registry on top of it. Now, that costs money, that does other things. That's probably not where we want to start in terms of dealing with stuff, but it is part of the process that what we need to do if we're going to consolidate things.
And just let me clarify something. As I said, I used an acronym UDRE. That's the Uniform Donor Risk Assessment Interview forms. So it was qualified. There's one for adult donors and one for donors less than 12 years old. So, child donors. So, because we have those two types, and then it's a little set up a little bit differently. But I just want to say that just like the blood DHQ, it was evaluated, qualified using cognitive interviewing techniques by the National Center for Health Statistics at CDC. So we had the same kind of process happen. And we thought that everyone would really buy into it because it does read more. It's easier for someone grieving because of the death of their loved one. It's just a few hours before they're asked all these questions. It really flows nicely, and we had so much input from the folks who actually administer those. So I think it's the optimized tool that should be used, but for some reason it's not used.
Well,
100%.
that's what I was trying to say, is that we need the specifics, that you have something already drawn up. I'm not trying to say that we need to make the decision, but I don't think the recommendations are specific enough with tools that we already have in existence. I know that recommendations need to be broad, but I feel like then there is no gap, right? We do have tools and we should make those tools integrated into the recommendation so that then they get teeth to them.
Ed, you have a comment?
We're just going to make the identical comment as Susan. The only thing I would say is utilizing the element of PIAF, pain in the ass factor. To the best of my knowledge, 98% of blood centers use the uniform donor history because it's so onerous not to.
Daniela Sridhar and then Sarah on remote.
As I'm listening to the conversation, to me, the number one gap is timing and identifying timing of deceased donors. And there could be 3 different time points. It could be the time at which someone registers for a license, which is what happens now. However, there's no follow-up on those individuals. The second is using our current blood collection process. We already have in place that it is mandated that a blood donor has to fill out a DHQ at the time of collection. So we have that in place. And then the third is when someone is admitted to the hospital. Now, there are a series of events that take place and there's criteria that's met. As I read these medical documents, we see at the bottom, this person is in critical shape, meaning that there's a chance of non-survival. So thinking about different time points, we can then be able to set up situations and criteria that allow people then to be identified early on. I think identifying post-mortem is not the best timing. And that's where we're running into what I've seen, the critical situations and when we're finding contamination events. So that's where I think we should be spending our biggest efforts. When I speak with medical students, what I like to say to them is that blood is a universal connector. Everything that we do, blood touches every organ. So, and I challenge you to show me what organ doesn't get touched by blood or how we are involved. But what's fascinating is by the end of the day yesterday, I became a little overwhelmed and I thought, gosh, how are we going to tackle this? So even though blood is that unifier, you know, Scott, you showed a beautiful slide how there's so many different types of tissues. And I think even though we need to have broad applicability, we might have to though think about approaching this in a very focused way and starting with the tissue that is most at risk. So I would say that we would start with timing, but also maybe narrow our efforts to the types of tissue that are causing us the most problems in terms of contamination.
Yeah, I think that comes up later in another work group's recommendations, but thank you. And this work group did look at donation authorization and informed consent, the processes that are in place, and routine referral, as it's called, from hospitals when there's an imminent death or a death, which is a requirement by CMS. So if you look at that section, they found that there were no gaps identified to try to do anything about that. Plus, it's also mandated by states and the Uniform Anatomical Gift Act, and there's that part. There's no potential recommendations for that timing piece that's related to authorization and informed consent.
Peter?
Yeah, hey, Scott, I don't think I ever asked you this, but I guess I was just wondering, is there something in the PHF 361 that prevents FDA from requiring more or less a DHQ? I guess that's what I was wondering. So
The PHS Act wouldn't actually go to that doesn't go to that detail, but we can look at that, I guess, and consider it. But
should the recommendation then just say FDA should issue guidance that more or less requires a standardized and related algorithms?
well, if we don't know if it's possible, I wouldn't put that in there.
But what would make it not possible?
Because I think and Ann's not here today. Maybe she's online. But we tried to look at what was happening in blood and how that helped by the professional associations coming together. The subject matter experts really putting it together, having it evaluated by NCHS, and then everyone uses it, and AABB keeps it up, and FDA reviews all the revisions. That is what we were hoping to get to with this wording, and maybe it's not clear enough, but that was the model, I guess.
No, I get that, but the problem is that people.
Sorry, I'm online. If there are questions, I'm sorry. I did join. I was on the wrong link. This is Ann Etter.
Yes, hi, Ann.
Hi,
Yeah.
Scott. Sorry. But you've described it correctly. It sounds like you were trying to get to where blood is, but it's very different for tissues right now. But
Yeah, when blood, when you review the DHQ that AABB and the other professional associations put together and keep up, how was that decision made? What's
Sure.
it based on? That you have a guidance document? Yeah.
I'm sorry. So, let me just very briefly describe that the AABB task force develops or keeps the DHQ, the donor history questionnaire for blood, up to date and consistent with all FDA regulations. They can include additional regulations that FDA does not require. They can include additional recommendations that FDA does not require, but we review it and we recognize it in a guidance. We don't require it, because there might be other ways to meet the recommendation. So our guidance basically says, the AABB's DHQ is recognized as a way to meet all FDA requirements, and points out what's not required, which we can't, require through guidance. But, it's taken up very well. I think just about every blood collector uses it, but we have to recognize that there might be other ways to also meet all of the requirements. But in any event, the recognition through guidance has essentially, I think, very effectively led to, in fact, a uniform donor history questionnaire for blood donation. I hope that helps.
Yes, I think that really the reason it works in blood is because the FDA, without saying explicitly.
It was a request. I used to have on slides what led to, it was to abate some of the recalls that were happening with blood and deviations, I think, because there was no uniform approach for screening a blood donor. So
Right. It made it easier for everybody because we didn't have to review so many different DHQs. It made it easier for the blood establishments. They knew that if they, used this one, that they would meet all FDA requirements. Yeah.
We have Sarah, then Benny, then Suchi, then Ray.
Hi there. Good morning, everybody. I have a comment and then a follow-up question. My first comment is from the hospital-based transfusion services perspective. Having federal oversight and registration requirements is critical. We quote the CFR, we talk to individuals about our biologics licensure in order to divest resources into the development of our quality management systems related to blood transfusion. It's very personal for me because my name is on our biologics license at my institution. But having that registration process and federal oversight, I think, cannot be understated. And without that, I think the system has the chance to fall apart. It's a true north for everyone in the chain of custody in blood transfusions, looking at the systems as a whole. So that's my first comment. And then my follow-up question is, in the subcommittee that reviewed this, was there a sense or an analysis done on the impact to the supply chain with tissues that now are going to be requiring standardized donor eligibility assessment? As one of the speakers mentioned yesterday, there are cases where there is no surrogate, it's a deceased donor, an agency is recovering certain tissues from them, and the individual may either be deferred or not even fall into the bucket of an eligible donor because there is not a capability of fulfilling requirements such as stated in number 1. And I was just curious if there was an impact to supply in that regard.
I think without a registry, we don't know the question on the impact of supply because we don't have the denominator in its current form.
Yeah, I didn't cover registration and listing, but it's in 1271. It's in subpart B. So that wasn't part of the biovigilance talk I gave yesterday. But there is registration and listing of products, HCTPs, that are required in the regulations, and that happens. And there's a public query. If you've never gone to it, go to our website for tissue and tissue products and go to the public query application for under registration. I think it says tissue establishment registration, something like that. But you can search for all of those who are registered and who have been registered before and are inactivated their registration. So that's all there. We have that.
Benny?
Yeah, thank you for the opportunity. I just want to make a comment that, I think that tracking is really a big issue here, and different tissues and different organizations probably have their own process. I know, speaking for the EBAA, we have a really, really tight process. We know the exact number of donors and the exact number of transplants that are done. We know all that information. It's easy for us to track. We've had it in place for, over a decade. And I'm sure other organizations have this. Some may be a little bit more cumbersome to track based on, distribution. I think the important thing is that each organization does have the ability to track and that we all talk. The communication between the groups is what's lacking here, I think. That's it. Thank you.
Agreed.
Tucci?
Hi, everyone. So just to echo some of the comments already made, but you know what, I think what it boils down to, right, is that for the blood donor side, the FDA has this requirement that any questionnaire used by a blood collection facility has to be reviewed. And it's that one requirement that then has led to essentially the development of the AABB Universal DHQ, and it's less onerous than to use that, which is already pre-approved, versus a center having to apply their own, but create their own questionnaire and submit it for that pre-approval supplement, which can take a long time, or takes time for review versus just using this already tool that exists. So what I find interesting, and I just went online to look at this universal, the UDRAI tool, and the questionnaire, the questions that exist on that, the flow charts that exist. That tool does already exist. And there are questions I have about that tool in terms of how is it updated? Is AATB involved in that? Because you do have, and I'm learning a lot of this from yesterday's talks, but there is an organization, AATB, who we heard from yesterday. And I wonder, were they involved in this creation of the UDRAI? And then also, how is it updated? So I did see yesterday that there are guidances coming out from the FDA that does provide information about donor eligibility for, I think I saw one for HIV, for Hep C. So when those FDA guidances come out, who then goes and updates that UDRAI? So it seems to me that there is a good tool that exists. There is a professional organization that exists and that could potentially, work like the AABB does. And then, I think the missing piece potentially is that FDA requirement that any questionnaire used for tissues needs to be reviewed and approved. And if that was there, maybe these other pieces would fall into place.
Ray, then Paul.
I think all of the recommendations are very good. I read through all of them. I don't know if we'll get through all of them today, but I think they're very good. I also think that the recommendations in 2015 were very good. I also think that the recommendations in 2009 were very good. So I want to take a step back and I want to say, what's lacking here, and I think we're seeing as a result of it, as Cassandra is saying, to dig down into the specifics, or Sridhar said, say this group is going to do what, is a RACI model. Who's responsible, who's accountable, who's consulted, who's informed? Because it's like that old saying, when you go into an organization and they say who's responsible for quality, and the answer is, well, everyone is. That's not a wrong answer. But the reality is, the question really says no one is responsible, because no one is assigned any responsibilities. I think if we take a step back and say, who is going to do these things? I don't think that it's our role, as Claudia said, to go in and provide the specifics of what exactly to do. So it's not our role. Whose is it? Who's going to do this? Who's going to implement these recommendations? Otherwise, again, 6 to 9 years from now, we'll be sitting back and saying, well, these recommendations in 2024 were really good, and they would have prevented these things from happening if someone had actually done something. So who's going to do it?
Are you suggesting then, and that's an awesome report you just gave, but should be developed by, and then have a descriptor there?
What tools exist, and use these tools as a example of what should be done. something like
I'm
that.
sorry, I know I wasn't called on. So these recommendations go from the ACBTSA.
Can,
Yeah.
can I,
I think that you guys can say FDA should do this. Ash to ultimately decide, right?
If we
Can I-
follow the AABB model, though, they would be developed by industry or professional associations. I'm not sure how we want to word that.
Right, but FDA ultimately.
can I weigh in here?
Lou, can we have Paul give his comment first and then you? Thank you.
Yeah, I just don't know how to use the hand function. Sorry.
Not exactly in line with what Ray said, although I certainly agree. Looking at these, we heard yesterday about a lot of the problems with the tissue source being from deceased donors. And I would just wonder whether here, the only way you're really sort of talking about deceased donors' involvement is sort of the related tools, which doesn't say a damn thing. So I'm just wondering whether that a standardized donor medical history interview forms and related tools for living and deceased donors. Be more explicit that that's a problem here in tissue, which is obviously not a problem with blood.
Yeah, just a reminder, the M. hominis transmissions were from living donors and amniotic tissue. So yeah, it would include both.
Lou?
So, Scott did a lot of the heavy lifting back in the day when he was a member of AATB on the UDRE. And when I say heavy lifting, it was a lot of work, collaborative work across many spectrums to put that together. It's my impression that the UDRE is predominantly used from AATB accredited tissue banks and their recovery partners. There is some flexibility where the medical directors of those institutions have added additional questions for their liking to the assessment, but the UDRE is in place. AATB is still working on updating the UDRE. We're currently pending the release of FDA's guidance document for donor eligibility to take the next step. AATB is willing to champion the updating of the UDRE and its promulgation yet again. So I definitely would put a flag in the ground on that one. And that would help twofold. One is that AATB can move faster than FDA when it comes to addressing sentinel events. One, two, on an ongoing and updating systematic process, AATB is better positioned to release updates annually, semi-annually, whatever. And the last component, we're trying to promulgate the standard questionnaire as one belt, and then the blood testing and the other specimens collected during the procurement that are analyzed as the suspenders. So for everybody in the room dealing with deceased donors, the UDRE obviously is the next of kin or the best historian for the person who has recently passed, the collection of those medical records that are in existence for that patient, sometimes very voluminous, sometimes very thin, and then the specimens, blood or tissues that are collected for testing. So we're always in a position of using belts and suspenders to try to ultimately to determine donor eligibility that a medical director would sign off on. But AATB would be more than glad to continue its work on the UDRE and the promulgation of that. At this point, we're waiting for the final issuance of the donor eligibility guidance, which is an important contributor to the next steps that the association and its members will take to address any gaps. Thank you.
Dr. Jang mentioned, Lou, that they're working together on, I think he was talking about the UDRE, because the IBank Association of America was intimately involved in developing the UDRE documents. So is that happening as well? And AOPO is not represented here, but they were also intimately involved in producing all the tools and the guidance documents and the UDRAs that were developed for an adult and child donor. So are they all involved in updating the updating you're talking about now?
I'm not aware of that, Scott. But it's an important point that on a go-forward basis that they be involved. But I can't speak to absolute knowledge whether they are today or not.
So with the latest round of updates, which were updated, it's on. Yeah. Thanks. I appreciate it. I want to make sure people can hear. With the latest updates, we did not go to the other organizations because we were updating things that were in the FDA guidance that had been updated over the past few years, which were not that many things. And they needed to be updated. And so it didn't seem like a big conversation to have to ask a few extra questions or to remove a few questions. We are waiting to get new guidance documents because that is where we need to have an overhaul of the UDRAs. And when we get them, we will have a larger group effort that is intended, and that's what we're going to do.
I have a question. There's been common points throughout. One is that the FDA needs to apply teeth in some way as much as they are allowed to. Another is that these recommendations, which are very, very good in spirit, need to be more directed. One of the directions is who is going to do this work. So can we say an expert panel should be assembled? Should we specifically say AATB should assemble an expert panel? Should we say FDA should assemble it? I think if we can decide on one of those, we can lay language down pretty quickly. I mean, I've done so, but I'm not going to presume that mine is the right one. That gives the direction that will put these potential recommendations into language that we can vote on. So, Susan?
Yeah, if I'm understanding the situation correctly, there's already a potential there's already some uniform tools available, and it sounded to me like the problem is uptake of those tools. So I'm trying to understand what it would take to create a requirement for FDA to review the donor eligibility assessment tool that a tissue bank uses, because as several of us have pointed out, that requirement for an FDA review is what motivated the uptake. So if the main problem is really the uptake of tool, then we should direct some words toward.
Yeah, I think I have a question for Ann because when one of the members made a comment about that the blood regulations require review of the DHQ. I just wanted to confirm that's correct. And is that because blood and blood products can be licensed products or?
Right. So in licensure, we review procedures related to manufacturing in the original BLAs, biologic license application, and in pre-approval supplements and conduct inspections. So in those pre-approval inspections and supplements, and original BLAs, we ensure that they're all of, since we're specifically talking about donor eligibility, that their process to screen and select donors meets all FDA criteria. So yes, it's part of licensure. Yeah.
Yeah, that's the restriction that we have is that, remember I showed you the two tiers, 361 and 351? That, there's no review by FDA of really anything when it's a 361 product, which these are that have been involved in some of these transmissions.
But Scott, couldn't you say that 361 still requires good manufacturing practices, right?
Right.
Good
So that
tissue,
might be,
good
I'm
tissue
sorry.
practice requirements,
Right,
yes.
but you could say that this would fall under that, right? I mean, if you have an inappropriate donor, that would seem to negate.
So it might be similar, although it's different. So, you know, licensure applies to facilities that intend to send blood components into interstate commerce. So I don't mean to sound like a regulator, but we don't review SOPs from registered only facilities that collect and manufacture and transfuse in the same state, within one state. However, they have to register. We can inspect them, and we can, and we do, but we don't review their SOPs. We review SOPs only for license. So I don't know. This is a long way of saying, you know, maybe the regulatory framework is similar. I don't know. And certainly the expectation is that registered only and licensed blood centers follow GMP and meet all of the CFR requirements. And if they don't, you know, we can take enforcement action. So that's sort of the framework in blood.
I think one thing we do need to consider, though, if the iBank has a U-Dray or a Dray, and they do because we share it with them all the time, and the organ bank has one and the tissue bank has one, it should be uniform. And I think if you don't include organ banks in having the same standard questions that they use, how they determine them as to be eligible donors is different. But if 33 of the organ banks also supply tissue, if they're using a different set of questions, it's going to cause a problem. So it really needs to be uniformed. If it's good for organ, it's good for tissue, it's good for eyes. How you release your donor may have differences for organs.
So if we could continue with trying to edit this too, I'm sorry, Jen.
So I thought that Sridhar actually kind of teased something out that I have found confusing as well. As a blood center who is implementing a new cell therapy department, trying to understand the differences between 351 and 361 can be challenging. And I think, so Susan was, her logic was saying, we got to make this regulation. And then Scott, you said, let's take a moment and ask Ann a question. And I think this is where our challenge is we want to make the DHQ something that's under regulation, but we have this difference between 351 and 361. And so maybe that's where our problem is. And if we can work through that is, and it sounds like.
Marilyn, then, oh, Jed, then Marilyn.
So I'm just in terms of comparison and sort of to latch on to some of the comments that have been made about this, is that for solid organ transplants, there's very clear, the OPOs, the organ procurement organizations, have very clear guidelines and questionnaires for donor eligibility. Blood sounds like as well, and somehow tissue is out there, and they're sort of using, you know, the OPOs and whoever is getting the tissue maybe extrapolating from donors of solid organs and bone and blood. And it sounds like the AATB is working to try to standardize, but I think that they should all be the same, right? HIV, hepatitis B, hepatitis C are universal for all, whether you're dealing with solid organs, dealing with tissue, dealing with blood, it should all be the same. There may be some differences with certain tissues, such as a time when Zika was being tested by the FDA for requiring that screening testing. So I think that it gets confusing. It gets confusing for OPOs who are saying, well, we have to get this test for blood, this test for, well, not so much for deceased donor blood, but this for solid organs, and to try to have a standardization, because I think it gets very confusing and people are sort of out there. And that would be my vote, is to have something standardized that would be required for both, for tissue and solid organ, particularly for OPOs, because they do so many of the tissue procurement.
Wordsmithing by committee is more painful than root canal.
Yeah.
That said, we propose that FDA be empowered to require approval of tissue donor screening tools. Professional organizations in collaboration with federal agencies are to be directed to maintain uniform donor screening tools, period.
So that's a rule change probably, which, you know, it takes a long time to discuss and clear, and if it happens even.
But maybe that's what's necessary to empower you guys to have the tools you need.
Can you say that again?
I mean, we can do it voluntarily as well. That's the other part. I was thinking when we're to reword number 1, that we describe who will develop the tools and the forms, and then recommended in guidance after review by FDA. You know, something like that, where it's done voluntarily, and then you don't have to wait for all the rule change to happen. And again, even if it would happen or not, it may not, because they may say, no, our regulatory authority doesn't go that far, which I think is what would happen, because we don't have review authority for 361 products. And to answer your question, Daniela, you mentioned something about 351s and 361s. Well, if you're 351 HCTP, your product falls in that category, which I think you're talking about, yours might, and your place. They have to follow subpart C, donor eligibility, so they would use the same form. Exactly. So there's a crossover there in that regard.
So in lieu of saying FDA, require FDA so that we can start moving on this more rapidly, can we say AATB and include in the language that we recommend that FDA be empowered?
And I think it
Well, you know,
has
what I
to
was
say.
what I
it
was
has
going to
to
do is just change number 1.
Yeah.
To be specific, which I was hoping we would get to today, actually. That's what I mentioned before. But if you take the idea that should be developed by professional associations, I don't know, that we can make that better too, and then put an IE there. AATB, EBAA, AOPO.
They want to say that it's consistent with the blood community. Well, I mean, I think the importance of everything we're going to do for regulation is to try to make it consistent across HHS. And you want the MPHO tissue side to be at least consistent with the blood side, and to use, and not to get separate.
Well, we looked at the DHQ and it didn't work for.
I don't mean to use
tissues.
the necessarily, use tissue use appropriate, recognizing differences in appropriateness. I mean, the blood community is a bit different than the needs, but that the processes are similar to update and to change and to do things. So,
yeah, and then I would add AOPO there.
yeah.
And you need to make sure you remember to put the voluntary, like FDA thing, what you said. What's the easier one to get? I think it's harder for us who are out here, like, you know, Jed and myself and all of us, to understand exactly which things can go faster and which things would go slower. But what we're trying to say is we want to be able to have teeth with it without having to make a new regulation. But it doesn't seem like if we're too vague, we're going to get anywhere, because that's what the recommendations were before. So we don't know where that happy medium is, but you do, because you just said if you make it a voluntary FDA thing, that will be better.
It would be a guidance recommendation that FDA would, that's how the approach would be this similar
Perfect.
to blood in that
Right.
regard. And that's the
And
model
that would be beautiful language, whatever we need, because that would be more specific than what this says right
well,
now.
and recommended in guidance by FDA. I don't think I'll get in trouble for that.
We hope not.
Scott, if you use the language recommended in guidance by FDA, does that really encapsulate the review and stamp of approval by FDA on that current version?
It would be a recommendation and guidance that ultimately probably says that, but not in those words, Lou. So it would be recognized. I think that's what Ann said. It's, you know, it's recognized by FDA as acceptable. And I think that's the same approach that would be taken.
Okay.
Could you add something about in a framework analogous to the blood donor screening process? So that we would reference what we're all thinking, that this is in parallel with the blood process, and just how do you, the core question we're trying to wrestle with is how do you, all this stuff exists already, how do you get the agent to various organizations to actually do it? And so in a framework analogous to, you know, that's what I was thinking, something like that, to think about that.
I think it's okay, but I'm not sure because that would, you know, the blood donation process has the educational materials that go along with the DHQ, and that is not possible with deceased tissue donation. So I just hope it doesn't confuse people to do that.
I don't think I agree. I think it would confuse people. I mean, the tissue regs and the blood regs are different, but what you're trying to do instead of, I understand what you're trying to do and it's a good idea, but I wouldn't, you have to do it within the framework of the tissue regs, not the blood regs. Because, you know, you have to start with the tissue regs because they are what they are.
And we do see that
who has authority to do what, and how do you make this happen within the current authorities? And yeah.
Yeah, we see that confusion. Thanks, Ann. When we review cell therapy products submissions, they think they should use the blood questionnaire, the DHQ, and that's not correct.
Cassandra?
So I was thinking more along the lines of organs than I was blood. And the reason I was thinking it, and I don't know from the statutes and what is regulatory, but I was thinking about I know we take more risks with organs, but a lot of the tissue that works is tissue that's not processed. It's, you know, live cells. I mean, that's what we need. And so some of the, you know, going to what Marilyn said, actually, can we use something that's more in line with organs? I know that they're not, and, you know, you got the whole vessel thing with the organ that comes, you know, the liver vessel and all of that. But it just seems to me that there is a lot of overlap with the organs, more than with blood, actually. And we really need to hone in on what products are the most dangerous, right, of the tissues. A lot of them are with live cells. They're not the ones that are highly processed and, you know, radiated or chemical treated and all these other things. So it's sort of, if you Venn diagram it, it's similar to the organ piece. And that has a lot of teeth, and surgeons are involved very heavily, like they are with tissue implantation. So there's just a lot of overlap in that sense. So I don't know whether we could say something like the framework that the organ procurement, and since a lot of the tissue banks are OPOs, I mean, they're just.
But it's already in there. That it's already approached.
But I'm saying that we do specifically say, instead of likening it to blood, framework analogous to blood, more of a framework that's analogous to organ. And maybe that's wrong too, because they have a different teeth than the license. But it just seems to me that there's a lot more likening that way and trying to be specific. That's all.
What's built into the UDRE, and if you look at the associations that were involved, OPTN policy is covered in there. Some of the, oh gosh, what's the acronym for follow-up on organ recipients? But that registry, that information that's required in the registry for recipients is also included in the UDRE. It's the way it flows. It asks questions that are expected to be asked for, say, a cardiac heart donor.
So we should point that out, because I think what's happening is the more specific we can be, the better off we are. Because I think when we've been too vague, so I just wanted to make sure, because I still don't think what you're explaining that thing says.
Yeah, I don't know about that framework language, because it's you can't get too specific. It has to be applicable across the board to organ, tissue, and eye donors, and it is already. That's the model that's created covers all that.
So these are the screening questions that are used with the donor families or the person who knows the potential donor the best. We use these. We use these every day. We work with 30 different OPOs and they all use this DRE. It is very widely used. It is not unwidely used. These are the screening questions. The part that let those donors that you're talking about, that you're so afraid about, was the final eligibility of the donors chart later in the system. So I think we shouldn't get overly, I agree, the organ, the eye, the tissue, we all need to be together. A uniformed one that we potentially, that most of us use right now is excellent. It should be used. But remember the donors you're talking about, it was the eligibility after the fact. They were probably no's on the list going down. And then when they got deep in the chart, there was more.
I have a question about the language in the third line should be developed. We discussed that there are tools that are in existence. So do we say something to the fact that should be reviewed and developed? And if so, is there a potential recommendation that's above one? There's another one that says review existing. And then maybe, but I'm not sure if, because many of us said tools exist, DHQs exist today, ACBTSA has developed these things. So is there a one before a one?
You know, could I clarify something too? When I added recognized by FDA, I thought there'd be a full stop there. And not go into that deep.
Okay. We're starting to be over time on the first set. So I'd like to suggest that number 2 and number 3 fall under similar, have a similar gap or lack, and that is specifics. So if we can agree that we transfer the specific language to 2 and 3 in some way, we can possibly vote on this sometime around lunch. No, I don't mean that we'll discuss it until then. I mean, we move on to number 2. We start, some of us start honing in on this language, then present it again so that we can vote.
So go to,
I'm just
so go to
suggesting
number
it.
2.
Go to number 2.
Okay.
Can I ask one question? How do we incorporate what Diane said? Because I thought it was really, really cool and important what she just said. And I think I definitely missed that step in this and want to make sure that that gets pointed out again, because, and I don't know where that fits. Like, I don't know if that's the medical exception part, like the medical discretion. I don't know who made that deeper dive into saying that where all the UDRE stuff was no, and somebody went in and said, but we can still do this. Because I know that, like, how many processors have said, I'm not going to do this. And then we go to another one and said, well, how many have you refused? I don't understand
Well,
that. And so
I
that,
see,
yeah.
I think I see what you mean. What Diane said, and it would be a big move should be developed and required by professional associations. That's what you mean.
There, that's.
Okay. Good point.
I'm sorry, Susan.
Yeah, I'd like to follow up on Diane's statement. So back to what's the problem we're trying to solve here? If the main problem is the definition of sepsis, it sounds like we're not getting to that problem with the donor eligibility assessment tool. That's a different issue. So I'm wondering if we need to separately address the issue of defining sepsis, and that could potentially be an FDA guidance document. So I'm not sure if the assessment of sepsis is not part of the donor eligibility assessment. It won't be addressed with what we currently have in recommendation.
And this wasn't really to attack that issue with sepsis, but that comes up, I think, in the next work group
Okay.
recommendations.
If
And
we,
then-
I'm sorry, just to quickly say, for number 2, to optimize control of contamination, effective practices should be required by professional associations, and recommended. So, and then somehow stick FDA in there as well. In guidance, yeah, thank you, sweethearts. Please say that out loud.
In guidance recognized by FDA.
If you want to make these all parallel, you could start at the beginning and just say that at once, and then it as a, as per the following, you can kind of format. But if you're going to say all this in 3 different ways, you could say it all at the top and then say as follows: 1, 2, 3. If you want to do that.
No, I don't think we could do that. I agree.
That's a good-
I
that's a
agree
good
with
idea.
it completely. I don't think we as a group of 25 should do that. But I do ask that our stellar staff get that idea, that the language that we've inserted into 1 and 2 are very similar. So if we simply place those at the top, ACBTSA recommends that the following be required by professional associations and FDA, and then put the language as subpoint. We can then, we'll take half an hour before lunch if we can and vote on this. If it works out. Yeah, shall we move on to the second? The second area? Is everyone okay, or are there any burning last comments? Burning last comments, Michelle.
This could be just a rhetorical question, but since the youth rate practiced and accepted by 90% of OPOs, I don't really understand why we can't say something like to mandate of the UDRE form.
Boom.
I guess for me, these words that you're using, maybe like doctor words, I'm not sure, but that could, I mean, why do we have the word could? That inform. And then, but even that word inform to me is so general, like that improves donor eligible, like the, or lines or universalizes. These words to me are very empty. Sorry, that is so, I'm just like trying to and close the gaps. It's like anymore. Can we just be like, we want you all to use this form and not to like, like this medical director from the OPOs are doing this. OPOs make a lot of money. Red Cross doesn't make that much money. There's like some conflict that these people are, am I like, I'm sorry, everyone's laughing, but you're making a face. I don't know.
That elephant was supposed to stay in the corner.
Am I off? I could be off.
I think
am
what I caught from,
confused that if there are people who are doing the screening with a financial incentive, isn't that something where we would want to require a higher standard of screening and make those donor questionnaires
must.
Sorry.
I
So
think
there's
it's a
no
good
room
idea.
for them. And I'm not saying that they are like, oh, I want these donors and I want to make more money. I'm not saying that at all. And I'm so thankful that there are people doing this incredible work, for health improvement. But at the same time, we, as a independent committee, kind of trying to make sure.
I think with your comment, we
Am I gonna
changed
be
should to
fired
must.
tomorrow? Sorry.
The must be
And
developed.
talk to me later if I'm off, because, you know, I'm so new. I don't.
No, no, Michelle, I'm making a note that a lawyer should always be required.
No, that's a good idea. Tools must be developed instead of should. I think that's really what you're saying, and that's clear. Okay.
Okay, we're gonna take a 5-minute break, and then move on to number 2. We're just going to, work with staff to make sure that everything is on the same page. So 5 minutes, literally, not sort of 7.
Okay, we are back together and we can continue. Scott?
So number 2, we changed should to must to be, or 1B. And then number 2, there's been some language added during the break, and we should make sure that there's discussion about that.
Can I say something about that number 2? So I think the part of that where we say that information collected from investigations and adjudication processes involving reports of probable transmission fees to organ or tissue recipients must be disseminated widely in a process developed by professional societies. I think that would be a little bit problematic for us because, so just to give you an example, so when CDC does an investigation of a disease transmission, so we report our findings back to the OPTN. The OPTN then collates that information and they make that publicly available through journals or whatever. And then when CDC has a notable investigation where we've deemed that transmission has occurred through an organ or a tissue, we do our best to also disseminate that through, you know, and so it's in the public domain as soon as possible. So that could be, for example, the MMWR. It could be a journal or something like that. But that's not a process that's developed by a professional society. Does that make sense? So
It does, yes. And even with FDA's review of MedWatch reports, that's not included here. And you know, that like the basic information I presented yesterday that we present at professional association meetings, that's not put anywhere on a website by FDA. And it could be. You know, so that this wording doesn't cover those scenarios like Streeter and I described.
I think I'm fine with that as long as but I think that part that's been added can just be removed. And then if as it was previously worded, I think.
Yeah, I agree. I think when the work group put this together, disseminated widely was included to the public or make it publicly available. It wasn't really restrictive, you know, but it would be de-identified information, that sort of process. Pretty sure that's what the work group was really talking about. It's like, you know, we want to know some information that's helpful to inform risk for anyone that would be a recipient, say.
Is everyone happy and ready to vote? Jim?
Yes, we can either do it, people raise their hands, or we can do a little.
Let's do a raising of hands, please, for all those, and let's do one at a time. For all those who vote yes on accepting the language of the first recommendation, please raise your hands. People online, please raise your hands. If you don't know how to use that, yeah, just go on screen and raise your hands. Okay, I think let the record show that there's been universal agreement. Can we have a similar vote on number 2? Please raise your hands. Okay, no dissents? Let the record show that there was universal agreement. And finally, recommendation number 3. Please raise your hands if you're in agreement with the language as is. Anyone opposed? Thank you very much. Congratulations.
Next, work group's recommendations. So this was the tissue processing group. They have 4 that were developed, and the first one, and I think I'll read through these again like I did before. To optimize cell and tissue products traceability from donor to recipient and back to the donor, the use of electronic systems must be required by health authorities. I just want to say you're going to see this in another work group's recommendations to follow. Electronic health records must have functionality to accommodate a variety of long, distinct identification codes that are assigned to products. And manufacturers' requests for product disposition information from end users should be required. The next one the processing group has is to overcome bioburden assessment and process validation procedures that are inadequate for detecting contamination of tissue products that pose the greatest risk to recipients. Microbiological process validation and surveillance programs must be effective, standardized by experts, and followed by industry. Number 3, to improve accountability and reduce variability that can affect recipient safety, donor eligibility determinations made by responsible persons should be independently monitored and non-compliance formally addressed. And 4th, to inform national standards, recommendations, and policies, cell and tissue donor screening experiences, donor testing outcomes, and data regarding use of products must be periodically collected, formally analyzed, and published every 2 to 3 years. So I think what we've been doing with these is trying to assign responsibility and make it clear, right? So for number 1, if we could focus on that one, what would you want to do? And does it sound like something that's actionable too? That's the other point. Yes, Ted.
As you showed, many tissue products include this little piece of paper for people to manually fill out. Is that suggesting there would need to be an electronic version? That's the way I'm reading number 1, which is not a bad idea. I find the paper form.
You know, the group wasn't really thinking about those. The implant information that's returned to a processor, they weren't really considering that at all that I remember. This was just the number in a system.
Number 1 is requiring an electronic version.
Yeah, this is just about the distinct identification code, really. Right, Diane, I think you might have been in this group, so I think that's what it was about.
This was just to make sure that the tissue didn't get mixed up inside. Not about the end coming back. It's only trying to make sure that what goes in comes out in an understandable fashion that meets standards that are set up by somebody.
Yeah, this is the processors talking about the end users, though.
I mean,
that's
when you say back to donor, that's the implant form.
I mean, everybody's going to use that quote unquote implant form, which is not universal. Some of them are actually. Some are provided online.
Megan, Sarah, Susan, Sridhar, Dave, Stroncheck, Lou. Megan, please.
Hi, everyone. So I'm new to the committee, so I'm a little nervous speaking up, especially that I'm virtual. But with this work group in particular, I wanted to ask, so with so many of those terrible cases we heard about yesterday, they were tuberculosis. And so I wanted to ask, what is the committee's, or this group's thoughts on requiring a better test for tuberculosis, either suggesting to manufacturers to create one, or if not already instituted, to consider instituting like a quantiferon gold blood test. So more really test focused than regulatory focused, but this committee is tackling these issues. And to me, that seems like a major gap.
Melissa, why don't you answer for AATB?
Yeah, so from AATB's perspective, we had a working group from the Physicians Council who looked at MTB for 2 years. We had published criteria and we wrote a review paper that was published in Transplant Infectious Diseases. So I think that industry has in fact created a lot of criteria specifically around tuberculosis, and we have already formed that working group, and we're moving on to other things that we're discussing like sepsis and medical director training and education.
Yeah, and remember, there's a guidance document from FDA that's planned. It's on our guidance agenda for Mycobacterium tuberculosis and sepsis this year.
Sarah?
Yes, thank you. For number one, I wanted to comment on the informatics piece briefly. I would request that we put wording in here for FDA guidance surrounding a tissue establishment computer system, similar to the way that we have a BEX system for the blood establishment side. And then secondly, on the question about actionability, I don't know, because I do know that our electronic health records at the point of administration, or in this case, implantation, is pretty challenging to modify the clinical records to document everything that we do on the lab information system side, thinking about those two things as comparable. But I do think that it's important to establish a standard for documentation purposes at the point of implantation.
Thank you. Susan Streeter, Cassandra, and then Dave and Lou.
Hey, I wanted to comment about what was just commented on. So specifically in Epic, they have a UDI place that you can put the device codes in, and they take a pretty long code. So at least Epic several years ago, and I'm sure it's better now, has a capability for implantation to be able to put some kind of coding. And so I do think that if we connected the dots, we'd be able to do some of the things, because I think that there's an allowance for it, at least in that system. But the other thing I was going to comment on before has to do with the end user part, and it has to do with what Jed was talking about. This is never going to work in collecting for adverse events if we don't have a capability of doing something electronic. All of these little cards, and I was in charge of a hospital tissue bank, and we had all different kinds of tissue. It is extremely hard to do all of that and get that back to the supplier with all the different pieces of tissue. And as far as HPI goes, and PHI and everything you want to say about HIPAA, there are problems with the way that's communicated back and forth to random people, and not necessarily always to a secure place. And so people want to leave off who the patient is. Maybe they want to put a medical record, but that's still an identifier. So I don't think that's universally figured out what the best way is. So that must thing about the hospitals and cooperation and all these things, there's a bigger worry and concern. We have concerns about blood and talking about what antigen typing people have from hospital to hospital still, let alone sending just pieces of paper back to to a tissue establishment. So I think that's a bigger problem for us if we want to connect, donor to recipient and back to donor kind of thing.
When I was reading, working with all the groups too, and I said in the beginning of this, that this one is found in another work group's recommendations. And what you're talking about, work group 3, what I'm talking about, it included representatives from Epic and Oracle Health. So they're one of the recommendations by that work group. This one is similar. What if we just take this one and move it to under the first one in the next group, and then you'll see how similar they are. There are differences, but they're very similar for these requirements for software. to be able to handle, these distinct identification codes. So if we could do that, cut and paste it to later, I think you'll see that once we get there.
Do Susan, Sridhar, Dave and Lou still want to provide your comments at this point in time or wait until we're on group 3? Okay, then let's move on to number 2. Thank you.
You maybe
Nay,
put it
nay,
as a
oh.
sub bullet there. Yeah. There you go. That's good. Thank you. So I won't read this one, but give you a minute to do so. I think for these, we might have to look at that first, add it individually and then see if we can do that. Yeah, very good. Where it says standardized by experts and followed by industry. I mean, if you read the gap analysis, it goes into the more detail about that, but it doesn't really, it's followed by industry. It implicates the industry will take care of this. So I don't know, what AATB, Lou, what you have to say, or
Lou and then Jed, please.
So Scott, what is the specific example, the specific tissue example for this bioburden process validation that was discussed in the work group?
Yeah, I'm looking in the report now. It was under bioburden assessment, culture method, and molecular method suitability. It does address what you can do with PCR and what it cannot do, which was learned from the MTB outbreak, the second one.
That's where I didn't get. I understand from my experience the limitations of PCR and why that failed when implemented by the MTB or the tissue bank that manufactured the viable cell bone allograft, and where it led to the second case in some regards. But I'm kind of, as an operator of multiple tissue banks in my career, I'm having difficulty with this one because we all go through process validation requirements and we're subjected to FDA inspection every couple of years as standard routine, and then specific if there is an incident or a concern with the manufacturer. I forget the words that are used for that special inspection, but nonetheless, FDA has a front row seat, and I've had to, in my experience, review my process validations with the agency at a number of locations using different methods. So I'm trying to understand how the work group got to this point, because operationally, I just don't see this as an ongoing concern for a tissue bank practicing the arts.
I think, just to address the FDA inspection, the capabilities are great, but it's a risk-based approach every year to who to focus on for an inspection. So it doesn't happen, there's no requirement that directs us to do that every 2 or 3 years or any period of time, actually. And some can be missed for a while. So we don't want to rely on that. I do know if you look at the report, the first thing the group talked about was AATB's guidance document number 5 that has a second revision to it, I believe, that everybody, the folks who were familiar with it, thought that was a really good guidance document and it must be followed, but it's not a must. It's just a guidance that AATB put out. Now, I was involved with that guidance document. I know that FDA provided some good input to it, for the 2 years I think it took to develop it, to revise it, and for the second version. So it's a well vetted guidance, and it covers all of this actually. Really, when you look at it, if you read it, the bioburden assessment and process validation procedures, it's all there. It's not found anywhere else. So, it's listed as the first part of the gap analysis by the group.
And conversely, AATB requires, if you're an accredited member, to have established validated processes, right? So, and then because of your work and other colleagues' work, providing that guidance document, on, again, sharing best practices on how it's done, then it's up to the individual tissue bank to either follow it or not follow it. At the practicer of the arts, I know that I relied heavily on the sharing and of that guidance document. It was incorporated in at least 3 tissue banks that I work for. So does this number 1 really kind of what you're asking for? The recommendation of the group is asking for that guidance be turned into a mandatory requirement?
I think that's what it's saying, yes. And if you read the beginning of that guidance document, I think it still says, like it used to say, because it wasn't revised, is that it will eventually be required by the association. But then that hasn't happened since, gosh, I don't know, it might be 10 years ago.
Yeah.
Jed, then Sridhar.
Borrowing Michelle Kim's lawyer's hat, my fear of the words "be effective" implies 100%. Our blood donor screening tests are incredibly good, but there was still an HIV transmission 15 years ago. So if you wrote mitigate risk instead of be effective, I think that would say you need to be doing all those things, but you're not guaranteeing 100% effectiveness.
Sounds good.
Yeah, I think when I look at this, I think we should not be limited in thinking about just TB. Had Mycoplasma hominis, and when the unused vials were cultured at a reference laboratory, they actually grew mycoplasma. It's also identified by PCR. I mean, I think when I see this, the problem that I see is that we have products that contain viable cells, and there's not enough surveillance of those to understand what microbiological risks. So, I mean, I think that when I look at this, I think there should be some sort of surveillance program that involves actual testing for emerging pathogens. That way, perhaps, there would be, and this probably should be something that's led by industry, right? At whether what you have are actually capturing screening tests are updated periodically when there's maybe new genotypes.
Yeah, I think what you're speaking to is in this guidance. It's method suitability testing. It's the suitability, the culture method, because there's inhibition that happens with many human tissues.
But it's to
Has to
detect
be overcome.
It's to detect known and described. What happened with TB? That's what happened.
And I think what you're talking about relates to standardized by experts. So, I don't remember if CDC was involved in this guidance document when it was created. I don't think so. So that could happen too, you know, so there could be more input from experts. It was developed by experts within the industry, you know. That's what happened, but
Stacy?
Got a question. So I think what you're trying to get at is a standardized approach to biovigilance. But we keep asking, you're asking industry to do this. And what I'm going to say happens in the blood industry is that we do it via our associations because it's the path of least resistance, because our other alternative is we're going to be inspected or dealt with on regulation. So even putting this into industry is not going to get the 30 or unknown percent, because what we've heard over and over again is we're not sure how many are not participating in AATB. So if we want to do this, I think the industry could absolutely set those standards. But if you want near universal following, you have to make following the way the industry wants you to do it, the path of least resistance, which means we're going to have some way for the FDA to put a little bit of teeth into it. So I either choose to go this way or I'm going to get inspected more frequently. I don't know if you can do that.
there was a recommendation, I think, for FDA guidance to be, there was a gap identified that FDA has a guidance document for process validation, and that could be updated. So maybe that could be added to this, right? I thought it might have been, I don't know, I didn't make the final recommendations because there were so many gaps identified that you couldn't fit it all in. So we picked the top, the group did, they picked the top 4 in this case.
A great job of doing this, and it sounds like they are, but to get all of the industry to do it has to be that we're forcing them to go to their industry association. That's not what's happening right now, or we know we have 125 out of 126. That's why AABB
That's a good
so
point, yeah.
effective.
Cassandra?
Yeah, this makes me think about when we put in for bacterial contamination for platelet testing, you know, and when all of that came about, how it came about with a letter that I think that Paul was on, that a lot of people wrote and just sort of said, this is killing people. And somehow, some way, things got changed even before we had the technology to do it correctly. And it's taken lots of time to get to where we are today. I feel like the catalyst with the TB and all the things should be likened to what happened with that and how we weren't going to stand for all of those deaths that could be attributable to the bacterial contamination. I mean, it was a monstrous change in the industry. And I feel like that only happened because, you know, FDA, there was guidance, there was a whole bunch of things that happened, and they really changed everything. And I would have to say that this last instance should be the last instance with the TB should really be the catalyst to change and be able to do this. And I don't know, it's that happened like in 2005, I think, is when that letter got written and things got sort of rocking and rolling for the platelet and bacterial contamination. We should be able to do a lot more now. So I think we need to put the teeth in and force whatever way we can to get this done. And if we could put specific language like we did before with the FDA in there, I think that would help us at least.
Should it say, instead of and be followed by industry, take away the and then add another one, and recommend it in FDA guidance or something like that, or updated in not updated, but recommended in FDA guidance. Yeah, I think that's what we did before in one of the other ones. Well, I'd say FDA guidance, there wouldn't be a. I hope the leadership goes along.
You're gonna be
Well, you know,
early retirement.
yeah, early retirement. So, I mean,
Marilyn.
Jim described the bot sec. We'll look at this too and discuss it. So there could be some changes made, and that's okay.
Just to point out in terms of tuberculosis that there is nothing other than history on an acute basis, you know, when the donor still presents, because serum quantiferin assays are not, the turnaround time can take a couple of cultures can take 6 weeks. There is an expert, something called an expert of sputum that's not done everywhere. So, you know, this is not going to solve what happened with TB. In terms of detection, I think that there, the problem is going to be in hopefully detection having to do with communication.
I think this will help a lot though, in that regard, from what we learned from the investigations. I really do. And, you know, you haven't seen the FDA's guidance for this yet, on the guidance agenda. So I mean, this is all, really all works together with that.
So that, that's in terms of risk factors, exposure, potential exposure.
You know, this particular one is about bioburden assessment. Accurately, and to recognize when there is contamination.
Right, but you're not going to get the culture results back in a timely fashion. Right?
I mean, I can't really
tell you
too much about that.
Unless they're in a
You know,
freezer
products can have a
somewhere
shelf
for long
life of a
time.
couple of
Yeah.
years. The products involved in the outbreaks were had expiration dates of like 2 years. I mean, 6 weeks is a real small part of that, but you know.
So is the thought then, and sorry to take up so much time with the weeds, but to on tissue up to 2 years to use that. Asking industry to do that.
Really talk about what's in a guidance before it's published.
Yeah, we're eagerly awaiting those guidance documents, and I mean that's the tough part about this recommendation, knowing that there are these guidance documents waiting to be penned. I couldn't vote yes for this recommendation at the moment because I'd like to see how much more educated I'm going to be with the next set of guidance documents.
Well, you know, like Treater was, he presented the M. hominis transmissions, and that would be included in this scenario to develop bioburden assessment and process validation procedures that would not allow that to happen again. So it's not all about TB.
Oh, I know it's not all about TB, but Scott, we all know that in a manufacturing setting, that however that mistake or that non-conforming tissue was allowed through the system can still happen again. You know, you can have a validated process not followed correctly by the operators and the technicians. And so on paper, you're validated, everything looks good, and then on execution, you failed. So for the audience in general, we all know that technicians, when they deviate from specific operating procedures, and when those standards are violated, you have non-conforming products that potentially can make it to the market. And obviously that was one case.
Yeah, you have to start somewhere, and you have to have the procedures, the correct procedures first. You know, human error we can't address, but we can address that you've got the SOPs and policies in place that are adequate. So that's really what this is about too, I believe. You know, we did have microbiology experts on this work group from the processors. You know, there was really good input from the subject matter experts here.
Mm-hmm.
I think they recognize that they might be doing the best that can be done by following the guidance document, but not everybody does that. And it should be something that is available to everyone. Okay, is that one,
Any other comments on what is now number one? We move on to number two.
okay, take a minute to read that one. So this one, if you looked at the report, it was about medical directors who can come from a variety of specializations, and they make the determinations of the of donor eligibility. About inspections too, that should be empowered to challenge donor eligibility decisions made by medical directors. Goes into a little bit about the responsible person making these decisions and their education. Even putting the medical chart together and reviewing all of the information, like could be 1,200 pages, but that was all used to try to develop this type of recommendation. Ed.
Are you requiring two-person check before tissue release, or are you requiring a post hoc audits of random charts? So is it 100% pre-release check? Is it a partial pre-release check, or is it a post hoc audit?
I'm trying to remember what the group meant by independently monitored.
Because I would read this right now as two-person check before the tissue is released.
Wasn't it a quality check before release is what it was? Like someone puts the chart together, does everything, goes to the doctor, and then it comes back out for the final quality check, and then it moves on. Because I think the standards right now address the quality aspects of it, but this is just being more directed, making sure everybody's following that.
Yeah, and I missed too, this was about septicemia and how there can be, it's the most variable donor screening factor. So that work, that's part of this recommendation too. If you look at the report, it goes, it should be black and white. So it was all about monitoring the decisions being made. And then, who would do that? Well, FDA does it at inspection. And they found deviations, we're finding deviations, and, there's actions being taken. Recalls are happening, that sort of thing, warning letters, if it's indicated. I guess part of it was the professional associations. It wasn't known what's being done on that end. When there's an accreditation inspection, say, I don't think we had much information about that. Sandra?
Yeah, should it be a must, right? I think the term was responsible person, meaning that a tissue coordinator isn't the person who makes a final determination, but the MD or the responsible person who actually can understand sepsis versus something else or risk factors.
Yeah, that's why it's plural.
So
It's not just the medical director. There are,
Do you want to put pre-release, like, so to Jed's point, so this is definitely before. But before, it's not an after, before release, right? This is decisions being made. Well, we might want to put that so it's more clear. Pre-release, yeah. But then kind of want to talk about who who is that? Who comprises that group? Is it the quality within? Is it like quality prepares all of that stuff and then it goes to the medical director for an assessment in the tissue bank? I mean, that's where I don't think this is like, it's very hard to understand the specifics of what we're trying to say here. That there is a compilation of information that's pulled together, and then there's a physician assessment based on, pre-assessment by two, independent individuals within the tissue bank or something like that. So then you kind of know that it, was looked at independently, I guess. But everybody's not in cahoots with each other. They're all checking each other. There are checks and balances.
Before release, I mean, a donor eligibility determination must be made. So when you put pre-release there, I don't know if it's necessary, but I know that we're trying to clarify what it says. But what would you, to your comment, Cassandra, what would you change?
Thinking about determinations made by responsible persons should be independent. The responsible persons is who I'm getting, like, who are they? I mean, so
I'm sorry, in blood, the responsible physician, singular, makes the final eligibility determination. And if it's not against regulations, we don't second guess the responsible physician. We might make additional recommendations if we don't agree with what they're doing. But just to point out that in the blood regs, the responsible physician, one person, is responsible for the final determination of eligibility. So it's clear where the responsibility lies. If you have, responsible persons, that's problematic in my view.
well, you could say there's a process to go to the responsible person, who is the medical director, that's what I was sort of getting at, is there is a process that you have within your system that brings the data, when people are looking at it from all their different angles, and then the responsible person, the medical director, is going to make a final judgment. I mean, the ultimate responsibility should lie with that person, but there can be a good process that brings it to that person. And then they, I think that's what this is trying to say. It just seems very not specific enough. So I was trying to tease it out.
Before you speak, Danielle, I have a comment, and that is, when I read through page 9 of the full report, I don't see anything about the pre-procedural agreement or review. I only see post. And that says to me that you're talking about inspections that are done afterwards. And if there are problems at a facility, that those inspections will catch that. But based on Ann's comment, if FDA comes in and inspects and assumes that the medical director has made appropriate decisions, I'm not sure what good that's going to do. An inspector would have to be empowered to do a medical review. And so is that what we're trying to say?
Well, they already are. I don't know
They
that
are.
you have to add it. And we don't use medical director in the regs. Guidance is not going to do that either. So it's a responsible person. But what we learned was that from the work group subject matter experts was that there are decisions made before it gets to the medical director to make. Sometimes the medical director isn't consulted and before recovery, because they look at the information and they make their own determination that it's acceptable. Okay, so then the recovery happens, and then other processes take place, and then a responsible person, which can be a medical director, decides to release the tissue for transplant. Now, and I can say, when there's a tissue type, and maybe I shouldn't name it, that needs to be the utilization needs to be used within a few days or within 2 weeks. There may not be a medical director involved who makes that donor eligibility determination, but it's a responsible person who's trained and qualified, but it's not a medical director. There is.
Maybe it has to do with then the risk of that tissue, where you have more intense
Well, it's fresh and
So-
refrigerated, so it's one of the riskier,
Well, then maybe that needs to be changed because maybe that's where some of that expertise of the medical director needs to be laid, tiered leveled, but that is a must, to have a medical director at that juncture as opposed to post.
Well, Dr. Jang, can you address that? I don't, that won't work for some sectors of industry. That you must have a medical director, that determines donor eligibility before release.
Okay. Yeah, I don't know. I mean, can somebody address that? I don't know why.
And then after that, then Daniela has been waiting. Dr. Jane, are you available? While we're waiting, Daniela, if you would.
I think that there is a continuum in point number 2 that starts at the recruitment and ends at post audit. And I think that the way that it's worded is what causes me confusion. So to improve accountability of the suitability, and so it's the suitability of the donor and sorry, it's donor
We
suitability
use eligibility.
and
there.
eligibility, exactly. So it's to improve accountability of donors, so many abilities of suitability and eligibility for the sake, it's almost like there's 2 items. So we want to understand who's accountable of the process from donor recruitment to the release of product. In my mind, I'm just again thinking of the cell therapy collections, because we recruit a donor and then at the day of actually collecting, there's another time period. And then once that donor collects, we do a post audit as well. So there's a whole continuum where a responsible healthcare worker, whether that's a physician or nurse, needs to be involved in the entire process for the sake of reducing variability that affects the recipient. That's how I see it.
Yeah, I think like others, I'm very confused about what the independent monitoring is intended to refer to. I'm not sure exactly whether we're trying to give some teeth to the assessor, the inspector, or whether we're trying to put in some criteria for acceptability. I just don't understand exactly what's the intention here. It's also not clear to me, back to Diane's comment earlier about there's the donor screening tool and then there's the medical record review. It seems to me that this is supposed to be including both, and maybe we need to specify that whatever the decision-making process that's reviewing donor eligibility that we want somebody to review I think we need to specify it's both the donor, the questionnaire and the medical record.
This is the accumulation of the entire chart.
Yes, okay.
When
then I
you're at
think
this
maybe we need
point,
to
it
specify
is,
that.
it's every part of it. It's serology, it's bacteria, it's autopsy, it's medical records, it's everything together. And, you know, the independently being monitored, I guess, could be defined in different ways. It could be a different medical director reviewing the same chart to see if they came out with consistent, you know, competencies and things like that. I mean, most processes, at least according to AATB, is there's a quality review first. When it meets all quality review, it then moves to an MD. After it goes to the MD, it goes back to the quality review to move it into processing or into release. So there are many steps that go into it. I think here they're just trying to tighten up that the person that there is a responsible for person is a trained responsible person, usually an MD, along
So-
with your quality department.
So are we recommending
Is that
that a
what you
second
meant?
check in real time? Are we recommending audits? I just don't understand exactly what it is we're
Monitoring,
recommending.
yeah.
This
And,
is
and then the
monitoring.
other, the other question I had is, do we need an FDA guidance document on sepsis, recognition of sepsis? Because it seemed like that was the greatest area of variability, and having a second check isn't going to get it that.
Yeah, and that guidance document's on the guidance agenda list for this year. So if, I think what's being said now is a little redundant and we can tighten it up. If you, and again, donor suitability is not a term that's used in the HCTP industry, or regulations, I should say, and guidance. So if we just take all that away, just keep in mind the variability issue, but remove all that was added there in the first part. Because we have donor eligibility determination made by a responsible person. That's who we want the accountability of. So that would go earlier.
Scott, does this have to be a ACBTSA recommendation, or is this just something FDA can?
Well, I think self-policing is one approach, and that doesn't seem to be happening. That's part of what this is what the work group came up with. It's not just me here. It's what the work group was saying.
So how would this be actioned? The FDA would issue guidance saying,
I don't know. It's all, I think it's probably covered in the quality program regulations. Current good tissue practice requirements. The group spoke to non-physician designees may also make donor eligibility determinations. That's what I was talking about, that happens today. So that's why it says responsible persons. It's not going to be a medical director. So that's why putting that as an example could be helpful. It's an EG, but it's not an IE. And if we say to improve accountability of donor eligibility determinations made by responsible persons, I think that's how it should start, because if we repeat it again, it's not going to be a good idea. Yeah, donor eligibility determinations made by responsible persons. Yeah, of donor eligibility can be removed. I think is needed to improve accountability of donor eligibility determinations made by responsible persons. Using established processes, I don't know that is helpful or not. I don't, what do you, I don't think so.
Did we lose pre-release by accident? Or did we lose it purposely?
I think we did. I think this is all post.
Oh, it's all post now, so we're not,
Is that correct?
But again,
The question is about release.
pre-release,
So
post retrieval.
From acquisition.
Right.
see,
So
the
pre-re-
idea was
so, but
that
it's
we're not,
pre-release,
we
right?
wanted to capture, the group wanted to capture those decisions made on site, basically.
So
And then it goes further. The recovery happens, it goes further, and then another responsible person reviews everything and makes another decision on eligibility.
But is that going to be looked at retrospectively by an inspector, like post?
Well, I
and then
think,
you-
the
or is it
idea-
going to be
the
done?
idea- The
yeah.
idea for audits that Susan brought up was probably, that's a good word to put in there as an example
Or
for monitoring.
should the timing be to improve accountability between acquisition and processing?
Recovery and,
Or
well, it
recovery,
can be,
excuse
yeah,
me.
we call it recovery.
Okay.
Even for HPC apheresis or cell therapy products, it's recovery.
I just am a little confused whether we're talking, I just want to make sure that when it's read, people who are not in this conversation understand that it stands alone as opposed, that we just define what we're talking about.
One of the things which is really important is that the recovery part of the tissue does not determine that it's going to be processed and made into a viable product for another person. That determination is the responsibility of the tissue processor in our system today. And so you can recover a lot of tissue, send it to a processor, and then have it rejected. And that's pretty expensive and pretty inefficient. And that's where people want to get thresholds for appropriate use of products that move from one person down that line before it ends up somewhere else. So what we're trying to do here is to put boundaries around the ideas of where's the responsibility steps to say that this is both efficient and efficacious for getting products that are truly useful into the system that they can be used. So there are multiple decisions. It's the one decision is, do we take this tissue and now move it into processing? And then the other one is, at the end of all the processing, do we release it? And those are two really very separate decisions. And we need to come up with language that says the people making the decisions that are going to move it from recovery into processing, that they know what they're doing and they do it in a responsible way.
Can I ask a naive question then? Because that was very important what you just said, that it all isn't going to be approved once it's in the tissue processing hands. But there is an expense to bring it into the tissue processing area, shall we say. And so now there's a conflict of expense, or am I misunderstanding that once you bring it into the tissue bank, I mean, you hope that you're going to use it, but again, I don't know. I mean, I'm not clear in understanding because there seems to be some kind of commitment there as opposed to not.
Yeah, it's covered in written agreements and contracts. That's how that's handled.
There's a certain percentage of donors that will be accepted through your screening process. You make a decision at that point. Up to 17% may not make it through the final process.
And you all just account for that because you
And
know
you
that's
account
going to
for
happen,
that, right.
Just like with blood, like, you know.
The majority of tissue banks do not process their donors until they have their donor eligibility determined, you know, for reasons of expense and everything else, and not having to be an emergent thing. Now, there are cellular tissues and other things that get processed early, but the independent decisions made by medical directors should in no way bear upon the fact that you've already processed or not.
Okay.
Should be eligibility at that point. Anne?
And was that a legacy hand?
No. Sorry. No, I don't have another comment.
Can we add non-physician designees to medical directors?
And then Glenn, do you have a comment?
So we're still struggling with who is the independent monitor. I'm looking at the report and I don't see that in the report exactly. They talk about surveys that were done by various organizations about rejection rates and so forth. But is the independent monitor within the organization? Is that some outside entity that's going to independently monitor the
work group?
What is the concept?
The work group referred to inspectors in general.
Okay.
And I think they were talking about for accreditation, the inspections that happen there, as well as the inspections done by FDA. I think that's what they meant by just general reference to inspectors. Inspectors should be empowered to challenge donor eligibility decisions made by medical directors.
Stephanie?
That's a good question, though,
So that's a very different, I'm sorry, that was my comment. So that's a very different construct than in blood, just to point this out. I mean, we don't practice medicine. We can't regulate the practice of medicine. I'm not sure I understand what you mean by should be empowered to overrule a physician. I mean, as a physician, I'm having difficulty understanding why the physician doesn't have the final decision, only because that's how it's done in blood. So if
Can
I'm
I ask,
missing something,
can I ask a question that's similar to me, to what Tim asked yesterday? Are we finding problems more often when it's a medical director versus a non-physician? No, the
Well,
problems are,
They can be related in any specific case. It can be, decisions made by two responsible persons that do not, they violate the regulations and don't follow guidance.
so if they violate the regulations, it doesn't matter who made the decision. It's violative. I'm not sure you need to empower somebody to overrule a medical director about their medical decisions. And you already have the regulatory authority, if they're violative, if they're not following requirements. There's a difference there. Maybe I'm missing something.
Stephanie, then Stacy?
Oh, yeah. So I was just going to kind of piggyback on comments made by Glenn regarding just clarity with respect to who is doing the monitoring. And also, I think it would be important to comment on who's addressing non-compliance. Is it that external monitor? Is this part of your internal quality?
Like I said, they were speaking to accreditation inspections and FDA inspections. So if we want to be specific, I guess we would put that in parentheses. Yeah, I would put it up. Oh yeah, I think it would be it would fit at the end, because non-compliance is addressed by both.
So maybe I don't understand this because I'm going to admit I don't do tissue, but are we addressing the medical chart review in this, or are we addressing the uniform donor or whatever we call it, UDRE? Because it seems like if the medical director is involved, it's about that medical chart review, correct?
Yeah, we call them relevant medical records, which is the term used for all of those records that could be used.
So I worry that we could be creating a slippery slope if we've got medical directors that are making this determination, and then the inspectors, who may or may not be physicians, are determining whether or not that was an appropriate decision. Does AATB already have guidelines on what is acceptable, things that should be looked for as flags in the medical history? Because I think you could create accidentally with this as an unintended consequence that the inspectors are now doing that second evaluation of the medical director. So I go back to what Anne said, where, well, we don't really question the medical authority of the medical director in the blood industry. But what we're doing here is we're actually empowering the inspector over the medical director because of a concern of inconsistency. So is the way to deal with the inconsistency to ask the professional societies to set some minimum requirements or flags that would say, if this exists in the chart, it can only go to this? And I'm dumb on this. So.
In the ATB case, Melissa spoke to that they're developing guidelines. They've developed they've published a manuscript for screening for MTB, and they are moving forward now with sepsis. So they're going to have guidelines that should be followed, and an ATB accreditation inspector can see if they're following those guidelines. I mean, but they'll have to be, I guess they split them up into recommendations and requirements. I'm not sure. But
that distinction was made like in the first pass after immediately following the second transmission case, because we had only gotten through part of our review. We weren't finished. We couldn't say anything. And that's the reason why there were some recommendations to look at these issues. But since then, everything is packaged up together as requirements, and they will be implemented in the standards when they get implemented next in the end of January.
So
Yeah.
could you revise this to say, to improve accountability, donor eligibility determination made by responsible persons should follow blah, 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 or must follow these guidelines. And then you're simply making the inspection and enforcement of the guidelines versus putting the inspector and the medical director in opposition.
It's similar to having a quality program that shows that the medical director has a process in place. That process follows blank guidelines. And so the FDA inspector would just have to review that that medical director or designee is following the practice stated in the SOP.
Is it follow FDA guidelines or is it follow
Yeah,
industry
I'm talking,
established?
speaking
Okay.
to the professional association and the iBank Association, they have medical standards and they have procedures and I don't know, Dr. Jang might know, but I don't know if they go further with guidance or guidelines for something like determination of risk for sepsis. I'm not sure. I don't think so, but maybe he could speak to that. So, again, this is more about professional associations making these checks. Not to override the medical director or whoever, non-physician designee that makes, but it's to learn from what's happening and should there be improvements. That was the idea from the work group.
And you could add, you determine the must follow professional association guidelines that must be updated on an frequent or occasional basis to kind of put the onus on the professional society to stay up with them if you felt like you needed to do that.
Lou?
I'm two things. One, I'm stuck on improve accountability because I really don't know what that means or how that's leveraged. And to get to accountability, what it may mean. There were recent warning letter issued to an iBank in New Mexico after an FDA inspection in response from the iBank to that inspection. And wasn't it about donor eligibility determination in the release of tissue product? And if it was, isn't the accountability portion the interaction as reflected by the warning letter through the FDA?
Correct. Like I said, the FDA piece happens when it's identified. So it's formally addressed by FDA. So and again, by FDA inspectors, I don't know that was where they wanted to come out, the work group. That was like there's a focus on FDA inspectors because you could have non-compliance to standards, professional standards that you ascribe to, and in accreditation policy of the AATB, it says you will follow the standards, right? So non-compliance can happen on not just with federal regulations, but also with standards, professional standards.
Yes, I think, Scott, they were trying to say that any inspector that comes in can look at any of your processes, including the release of your donor tissue, which was done by the MD. So it was just opening it up to allow any audit or inspection process to look at all the records, right? Yeah.
Trying to see if this is what the work group intended.
I have a question, if I may.
Yes.
So it says up there, it says it must be formally addressed by inspectors or auditors. And I think I just heard Scott say, and that's the reason why I'm asking, is I don't want to make sure I understand correctly, that perhaps with the warning letters and FDA inspectors are looking at, some of these donor eligibility issues, I think really for the first time that's being looked at very carefully by FDA inspectors. That it maybe isn't the inspectors who are making those decisions, or donor charts being sent someplace else for review. And so that I asked that question because I wonder if that shouldn't be addressed by inspection or audit as opposed to the inspectors or the auditors.
Yeah, that's a good point. It would be by inspection and audits. Yeah, exactly.
If-
Not the persons, but the process.
If a facility is not AATB accredited, is it only FDA that's inspecting?
Unless they're have a state license requirement where they're located, or if they send for like New York State, they license tissue banks inside the New York and outside, but not, states. There's only a few states that have requirements for tissue banking or regulations that address.
I also think that must be frequently updated is a pretty loose term and should just be struck, should be maintained, should be current. Yeah.
I was wondering though, the term must, on one hand, we want to empower ABT to utilize the guidance that they've created, but is that a strong word, must follow?
Say it's on purpose to
Okay.
to make it must.
It must be. And then just one more point. We did say this a few minutes ago, but we are under the section of tissue processing. Do you want to be more clear about where this accountability is taking place? So to improve accountability during this time period, or you wanted to leave it more broad?
It should be broader, yeah, because it should be about the responsible persons involved. So it happens at recovery as well.
Right.
The processing group recognized it.
Yes.
It's, it can happen at the processor, but it can also happen earlier in the process.
Right.
At recovery.
Okay.
Did it say which must be maintained by those associations, or it should just say be current?
Yeah, it must be current would be good. Yeah, follow current professional association guidelines. Yeah, thank you.
What do people think? I mean, there's been a lot of concern about the looseness, about the inability for an outsider who has not sat in this room to understand this. Do people feel that we have arrived? Michelle?
Oh, sorry. So, that responsible persons, it's not a defined term. It is defined later on in the note. And if you don't read the notes, instead of saying responsible persons with a few examples, can you just say persons who make donor eligibility? That's how it's defined. Make it a little tighter. Sorry. I withdraw my sorry.
It's a regulatory term. Yeah.
Okay.
For the HCTP industry.
I mean, I think if anything, I don't think you should remove the word. I think you should use the words that are in the regs because they're defined in the regs. But to your point, I think it would be fair to define it in the thing, in up here. Yeah, in the recommendation.
Yeah, I can read the definition for you. It means a person who is authorized to perform designated functions for which he or she is trained and qualified.
So please.
So it's a known term,
Okay.
Term of art, I guess is.
So please go back to the original language for that. For person to respond.
Yeah, the original language. We don't need to add the definition there.
So for a tissue bank that is not a member of a professional association. This recommendation basically is saying that all tissue banks must follow guidelines published by a professional association. But who can enforce that? I don't think FDA has the authority to. So when we say
It was discussed to be the accreditation inspections.
what about the organizations that are not?
Right, but if you want to capture a large part, as was described, of the industry, then this would do that.
We're still going to have TB then.
Yeah, I think we need to just, if FDA has to see them all, FDA is the bottom line, right? They all have to apply. Yes?
Right, but working together, we can really make it work.
No, I'm not saying that, but at a minimum, this won't make the other people join AATB. But we have to get them to comply, and FDA is the only common denominator for all of them. So I don't think this is the right one to suggest that they all belong to a society.
Oh, no.
But I think it's the way to get them to do what we're asking them by putting FDA at the end, because it's the common denominator. That's all. I mean, I think that they're the only ones who are going to come in and inspect the ones that aren't part of a society.
I mean, that's my question. I am guessing that an FDA inspector cannot require compliance with a professional association.
No, not at all.
No.
Not at all.
Yeah, we don't. No.
Yeah, if we have accreditation, we have inspectors from societies, they can do this. FDA cannot do this. So how do we cover the places that are not accredited?
We don't. It's a gap.
Can the FDA?
Has to fill that gap with their
Yeah, I was going to
periodic.
say, so can FDA, can we have some way?
We can cite folks for not following their own SOPs, and that happens. And if their SOPs follow the professional association guidelines, but they're found not to follow those guidelines, if it's related to a regulation, then it can be cited for not following their own SOPs.
Yeah.
Yeah. But I don't know how you're going to capture that here.
This recommendation is just not landing well.
Well, this is a really important part from this work group. I don't know if you were in this one, Lou, but the processing group they made a couple of gap observations related to this one. And they were not happy with what was discovered.
I mean, I think that to the extent that FDA has guidance that deals with, what's expected, the decision-making process in reviewing the medical record, then we would want the FDA inspector to be able to question, the decision-making process around the medical record. So, but they can't refer back to the professional association guidelines. So if there is also a gap of FDA inspectors not feeling empowered to review compliance with, any FDA guidelines, then or to FDA guidelines.
Well, that's the New Mexico iBank example that I brought up earlier. I mean, that warning letter took a period of time to come to that point, but there's definite accountability to the regulations regarding donor eligibility determinations and subsequent release of tissues that were judged by FDA staff to be non-conforming. So there is that accountability factor. I wasn't a part of this group, and I'm wondering what's underneath the waterline here that I'm not seeing, which could potentially be the most concern from the group that really is not reflected in the write-up report or reflected here in the recommendation. Dr. Greenwald, can you touch on what AATB has in the work pipeline for medical director aspects post MTB?
Well, there's a lot, actually. We're looking at training programs, and thinking about how to make information accessible. We're thinking about what requirements might be for medical directors. And frankly, we've only been at this for a few months. We've actually got a lot of ideas floating around, and we're, having to systematically go through and think about those things. But I guess what I'm saying is I don't know exactly what all that is. I I still don't really understand this number two. So maybe Lee, is there something else specific you want me to speak to that I'm just kind of fumbling for here, that you can help me direct me where you want me to talk to?
I always found it a challenge to, at my different tissue banks, to find a medical director with close enough experience and time they could commit to being trained and educated on the tissue banking industry and then the donor eligibility component, and exercising their professional experience and certifications and so on, from the training to a really tightly controlled donor eligibility process. And I think, as I've stepped to, I'm out in the tissue bank operations side today, for work, but I have a concern that we're not backfilling the pipeline of medical directors within our space. And so I see a need for ongoing training and education, and the sharing of best practices and history, most importantly. And that's where I feel like number two is searching to say something along those lines, but not saying it.
Yeah, and number two seems to be saying that it's up to the AATB inspectors, not even the FDA inspectors. It's all up to the AATB inspectors to figure this out.
Maybe a
But
suggestion.
I just
Yeah.
I'm going to, the thing is I think Lou was 100% right that we don't necessarily have enough medical directors in the pipeline, and that is something we're specifically addressing. And we are developing a training program for new medical directors. Thinking about that, because I have a bunch of medical directors who are all like hungry for information. They're trying to get more involved in activities around tissue banking, and they are excited and anxious to be creating some training programs for medical directors, because unlike in blood banking, we have medical specialties in that, right? We don't have a medical specialty in tissue banking, and so that is something that is definitely being worked on. And I think that should help, although I'm still not clear that entirely addresses number two, but I think it's certainly part of it. And thanks for bringing that up, Lou. I'm sorry, Sridhar, go
Yeah,
ahead.
no, I was wondering if this should just say to improve accountability of donor eligibility determinations made by responsible persons. FDA should require independent monitoring, and non-compliance with these should be formally addressed.
Yeah, I was going to say these determinations should be monitored and non-compliance addressed by inspections and audits by professional associations and FDA.
I think it should
Something
just
like
say
that.
FDA. FDA should.
No, well, self-policing is important, and that's what the group was talking about too. So they thought there could be more done, and like Melissa's actually describing, that's exactly what they want done. So that self-monitoring was important, not just relying on one entity to do that.
Ray?
Reminds me of one time I asked someone in an organization that will be unnamed, why don't you have SOPs for this? And the answer was, because then we'd be expected to follow them. And this seems to be that there's a gap that basically, where you're saying if you're a member of AATB, you need to follow their appropriate guidances and policies and practices, and you will be inspected in order to make sure that you're complying with that. But as Claudia said, what if you're not? Is the issue more about saying that you have to have institutions that are going to undertake these practices have some form of accreditation, whatever that may be? Because in the absence of that, if you allow both, then why should I, as an organization, want to join an organization that's going to require me to do things in the proper and appropriate way? If I don't want to be a part of it and I can still operate outside of it, won't I do that? If it's faster, cheaper, and easier. So I think in the context of this, if it's not FDA saying you have to do this, or someone saying you have to be an accredited institution in order to participate in this field, that resolves the problem, because then you have to follow someone's policies, practices, and guidelines. Today, it seems that you have a choice. Why not take the easier path?
So if we put, working off of that, these determinations should be audited. And non-compliance addressed. I don't know if we want, I know it's making it broader, but non-compliance with regulations, standards, guidance. Standards would I put in there too. Regulation, standards, and guidance.
I'm sort of where Ray is. I'm a little confused why we can't just use the FDA, because we can't force. I mean, look at CAP and ABB. Look, I mean, there are teeth as to why people drop different. They don't want to pay, and nobody can make them do it, even if you want to have a higher standard. But everybody has to comply with the FDA. I mean, and if that's the only common denominator, I don't know why we're saying something that we can't enforce, when the only thing we really can enforce is the FDA part.
Okay, I mean, and we can do that, and it's happening already by
Right.
the warning letters.
Right. But we should, but maybe being clear here about, I mean, at least it answers the working group. The working group is saying that this is important, regardless if it's enforced by AATB or ABB, FDA. So as long as we're addressing this, we are looking at it more specifically, what the working group wants to accomplish. We're just trying to tie it together with the ones that are not participating with AATB. If we want to have a different kind of recommendation that says we recommend everybody be AATB.
Well, you know, again,
that might be.
we've already identified 3 professional associations and other recommendations, and this discussion didn't happen for that.
Right.
I'm just saying. So why we're so reluctant to include professional associations now, and we also know that, you know, there's going to be some who are not accredited by anyone. I guess I'm just worried that we're going to lose something by not identifying and being specific that the professional associations are part of this.
Yeah, we're part of it. But I think what everybody's saying is FDA's feet need to be held to the fire too. I mean, ultimately, FDA regulates these products, and FDA has the authority to make people do stuff if it's not in compliance with their regulations. And so I totally agree that having both involved is important. But I think people are saying, why isn't FDA also named in here? Why is AATB solely responsible for upholding FDA's regulations?
Oh, no, I'm all for adding FDA. I've already said that. It's just not there yet.
FDA and/or. I mean, what it is the problem is that the only one that you can make people do is FDA. But if you want it to be higher, you can say AATB in there, and then that, you know, has it.
And the iBank Association. They
And
have
the iBanks.
standards.
But I think the one that is definitely is the with FDA and or these other ones. That's a way to include
Okay.
everybody, but not say that they have to do that, but everybody has to comply with FDA. And calling FDA out as the one might be the way to go.
And maybe it should be reviewed at inspection instead of audited. Audit.
Benny?
Yeah, I apologize. I had to step away. And so I understand that there was a question that was addressed to me earlier that probably was already addressed regarding the medical director and non-physician designees, as I see here. I'm happy to take any other questions, but I also did want to comment that whoever made the previous comment just now about the FDA, I fully agree with.
Sridhar, what was the original language you recommended? It was a sort of a full stop.
Yeah, I think it was prove accountability of donor. FDA should require independent monitoring. Non-compliant should be something like that.
I asked Benny the question that was brought up to specifically ask him, which we didn't ask him, but it sort of got addressed. Benny, if you're still there, this is Cassandra. I just wanted to ask you, there was a mention made that in the iBank context, the medical director isn't always able to be accessed. And so the way you handle that, is that by having a non-physician designee? Is that why you think, or I didn't know if it got addressed to you? That was the question that Scott was asking you.
Yeah, I apologize. But yes, that is exactly true. A trained non-physician designee.
Okay, but that ultimately answers to the medical director, kind of like the way we do it in blood banking, I guess.
Yes.
There's a designee. Okay.
Correct.
Thank you.
We
Thank
need to break for lunch. Can people do lunch in 30 minutes? And be back in here? Is that too draconian? I hear 40. 40. 40 minutes, we're back. 12:45. Please, everyone, thank you so much for your engagement.
Produced by the U.S. Department of Health and Human Services.